everyone to the seminar. We'll give just a minute for our attendees to join and then start with some introductions. And while everyone's joining, I'll make an announcement about our next seminar and also let you know we always appreciate evaluation feedback. We'll be chatting out an evaluation link near the end of the seminar and encourage you to complete that. So welcome to today's seminar titled Safer Slopes, EMS and Trauma Data and Ski Patrol Perspectives on Preventing Ski and Snowboard Injuries. It's part of our Research to Practice webinar series held every second Tuesday of the month at 12 p.m. Mountain Time. The next webinar that we'll host will be August 10th, Tuesday, August 10th at 12 p.m. Mountain Time. And the title of that seminar is Using a Positive Youth Development Approach to Foster Healthy Futures for Maltreated Youth, Challenges and Opportunities in Community-Based Implementation. And our speakers at that webinar will be Dr. Heather Tausig from the DU School of Social Work and Megan McLean from Adoption Options. So we hope that you will join us next month as well. But let's turn our attention today back to ski and snowboard injuries. The thought was it would be nice on a warm July day to remember that it snows here in Colorado. We have so many opportunities to take advantage of the mountains. I'd like to introduce our speakers today. We'll be starting by hearing from Dr. Lauren Pierpoint. She's of the Steadman Philippon Research Institute. She'll be presenting some epidemiological findings on injury patterns at a Colorado ski resort and discuss the implications of those findings and the importance of involving resort, physician, and ski patrollers in data collection. And then after that, we will hear from Amber Viitanen. Oh, I messed it up, Amber, I'm so sorry. Viitanen and Scott Beckley of the Emergency Medical and Trauma Services Data Section at the Colorado Department of Public Health and Environment. They're going to describe how EMS and trauma registry data is collected and the limitations of these data. They'll share data on characteristics of ski and snowboard related injuries in Colorado, including the type and timing of injuries and the demographics of people affected. So I'll be turning it over to them. As a reminder, you can put questions in the Q&A at any time, and then I'll be moderating a Q&A towards the end of the presentation. And with that, I'd like to turn it over to Lauren.
There's the unmute button. Hi, thank you so much for tuning in to join us today for the Skiing in July webinar. Thank you for the introduction. I'm excited to talk to you today about some of the work that I did as a part of my dissertation at the Colorado School of Public Health a couple of years ago in collaboration with Winter Park Ski Resort. And I became interested in this topic as a volunteer ski patroller for 6 years at another resort. And maybe you're tuning in today because you ski like most Coloradans. Maybe you have a kid that skis, or maybe you're in the industry and want to know about what type of data are being collected out there. So today I'm going to present data collected from Winter Park Ski Resort over the course of 5 seasons and talk about what we have learned from this data from an injury prevention perspective and a public health lens. There are millions and millions of people who participate in skiing and snowboarding each year. And this nice graphic put together by the National Skiers Association shows the annual participation information and breaks it down by activity. And there are over 10 million active skiers and snowboarders that participate in the US each year. And that adds up to more than 50 million visits to US resorts. And 500,000 Colorado residents are responsible for this participation information. And so you might not be surprised to learn that given the amount of participation, skiing and snowboarding are associated with a relatively high total injury burden. And this triangle represents the different levels of our understanding of the injury burden of skiing and snowboarding, with the most severe injuries, including deaths and hospitalizations up top, and the less severe injuries on the bottom. And we don't actually know how many near misses occur in these sports. So like you fall and you don't get injured, or you narrowly miss having a collision with someone. We also don't know how many people become injured at a ski resort and just don't seek treatment. And we don't actually have very good estimates, besides on an individual level basis, of how many people are presenting to ski patrol after they become injured. We do have a little information that says that up to 600,000 skiing and snowboarding related injuries are treated in doctors' offices in North America, and that up to 140,000 injuries are treated in emergency departments, 5,000 of which will be hospitalized. And then finally, at the top of the severity in the pyramid are deaths, and approximately 40 to 50 occur annually at US ski resorts. And so that's a little bit of the information about what we know about the total burden of ski injuries. And we also know a little bit about rates from the National Skiers Association, who conducts a study every 10 years in which representative resorts are selected to report injury information collected from ski patrol incident forms. And I love that this is going on, that this study was undertaken, but I'm disappointed that rates aren't going down as much as some of us would like to see. Rates of injury in skiing have remained virtually unchanged, maybe a slight decline over years. And I've heard the argument that this is rate stabilizing, but I don't really agree with that sentiment. I don't think anybody truly believes that we have bottomed out and there's just nothing more that we can do from an injury prevention standpoint in these sports. And I think there are a couple things that we can put more focus on to make a bigger dent in the problem, one of which is understanding the landscape of injury burden better and to a deeper extent. And two is changing the focus away from trying to shift individual behaviors to considering injury prevention efforts at the environmental level. And I'll talk more about that later. But when we think about injury problems as a whole, what should we be targeting for injury prevention? And we can think of injuries as a combination of severity and frequency. Some injuries are very severe, but not common. And some injuries are very common, but they're not severe, and there's not a high mortality or morbidity associated with them. And when we think about injury burden, we shouldn't just be targeting their incidence. We should be focusing on total burden, including morbidity and severity. So that is my first point, in better understanding the landscape. My second point is that while some injury prevention measures for skiing and snowboarders exist, like those listed on the left-hand side of your screen, they all have one thing in common, which is that they rely on implementation from at the individual level. And this graph, I learned about this from Dr. Carol Runyon when I was in school at CSPH. And it's just a really simple graph that represents the literature out there that shows as individual level effort increases, the effectiveness of any given injury intervention goes down. So the more effort someone has to do on their own, the less likely they are to adopt that intervention. And those on the left are pretty much all individual level interventions. So what do we do? And I think that environmental modifications are often overlooked. This graph on the left just shows a causal model for injuries. And I think it's overlooked because in injury prevention efforts, a key factor is the environment. And in skiing and snowboarding, the environment is just inextricably linked with participation. You can't take the environment out of skiing and snowboarding. So if we can understand its potential effect on skiing and snowboarding injuries a little bit better, maybe we can modify the environment, which you might see some of these and be like, you can't modify those. I'll argue that you can modify a couple. To just reduce or remove the potential for injury causing energy transfer. And so since ski resorts have designed and constructed the skiing environment, I think it is reasonable to believe that we can modify or at least react and modify our behavior in response to environmental conditions. So I have two objectives today that I want to pass on to you. One is to describe and compare injury patterns between recreational skiers and snowboarders from a single resort. And the second one is to give you information on the extent to which environmental factors influence injury rates. And I started out doing this work with the long-term goal of reducing injury rates at ski resorts and providing areas for more targeted intervention efforts. And I wanted to be able to help resorts collect, interpret, and use data that's frequently there in terms of EHR or ski patrol incident report forms. And so to do this, we undertook a study at Winter Park Ski Resort during the 2012-13 and 2016-17 seasons. And in order to be included in this study on injuries, the person had to be injured at Winter Park as the direct result of skiing or snowboarding, and they had to sustain a musculoskeletal or internal organ injury. And they needed to be treated at the East Grand Community Clinic and Emergency Center, which is important because it's a medical clinic that's located right at the base of the resort that you can almost ski into. Exclusion criteria included injuries that occurred during other activities as well as environmental illnesses. And we did exclude injuries that were not treated in the clinic. And the reason for that is because the clinic is staffed by physicians and they can provide a definitive diagnosis of an injury since they have diagnostic and radiographic imaging available. So at Winter Park or at any resort, really, you can become injured on the hill and you can be rescued by ski patrol, or you can ski down to ski patrol under your own power and then be transferred to the clinic. That's one way that we got our participants for this study. The other way was people bypassing ski patrol altogether or just going directly to the clinic. And for those of you unfamiliar of where Winter Park sits in the landscape of Colorado, it's highlighted in yellow where the community clinic is. And this is important because all of the higher level trauma centers are located at least 20 miles away from Winter Park. So what we think this means is that we can be confident that we are capturing the majority of injuries are in need of immediate medical attention since the next furthest centers are so far away. And we got our data from several different sources. The first being our injury data, and we collected that from the East Grand Community Clinic and Emergency Center, which is affiliated with Denver Health. And they had an electronic health record system that we could pull from. But this required retrospective chart review until 2016-17 when it went fully electronic and made data collection much easier. The second source of data what came from Ski Patrol, who provided us with really good information about where the injury occurred and information about the injured person, including skiing equipment, helmet use, and their ability level. And we linked this information to clinic records by name, and that says date of birth, but it should be date of injury, I apologize. And finally, we got historical weather records, including information on visibility, how much snowfall the resort got, base depth, and the condition of the snow, like powder, packed powder, spring conditions, from Winter Park Resort Management, who I just want to give a lot of credit to for being very easy to work with throughout this whole process. They also gave us daily participation information, which is participant visits. So it's the number of people who scanned their ticket or pass at least once during a day. And I do want to point out that this is not stratified by any other characteristic. It's not broken down by age, male, female, snowboarding versus skier. It's just the number of people who are at the resort and took at least one run during a given day. So that wraps up how we collected our data. And I will dive in and provide you with some results and some information about the injuries that we captured. So this represents 815 operating days over the course of 5 seasons. And on any given day, you had 0 to 29 injuries treated in the clinic. Some days the resort was pretty much empty with 300 people there, and some days there were close to 20,000. But we captured close to 4,000 injuries and over 4.5 million participant visits for an overall injury rate of 1.37 per 1,000 participant visits. And what we found when we broke it down per year throughout the duration of the study is that injury rates did not change. On the left-hand side, you have raw injury counts on the graph. On the right-hand side, you have rates per 1,000 participant visits. And the graph shows that there was no significant change over time. Then we asked the question about who gets injured. And then we made comparisons between male skiers and snowboarders using chi-square tests if they were categorical and t-tests if they were continuous. And if you have more questions about analysis, I can definitely answer that for you in the discussion. But we found that a greater proportion of injured snowboarders were male, and that's pretty in line with previous findings, and a greater proportion of injured skiers were female. And most of our injured participants were not from Colorado. The majority of them were either from out of state or foreign, from out of country. And most of the injured population consisted of beginner or intermediate skiers and snowboarders, with beginners being slightly more represented in the snowboarding population. And when we looked at who was wearing a helmet at the time of injury, there were no differences between skiers and snowboarders. Consistent with prior studies, mean age was higher in skiers, so skiers are older. And then we look at where people are getting injured. And we find that most of our participants were injured on beginner or green or intermediate blue runs. And that's consistent with our other finding that most injuries happen to beginners or intermediate skiers. I do want to point out that very few injuries happen in double black or advanced terrain, but that a greater proportion of injured snowboarders were injured in the terrain part compared to skiers, and that'll be important for talking about injury prevention later. Now, when we look at how people are getting injured, we broke it down into a whole bunch of categories, but I want you to just look at the top three and notice that the majority of people are just falling down and hurting themselves. And that's consistent for skiers and snowboarders. But an additional close to 20% of injuries among skiers are due to collisions with natural objects like trees or with other people, and close to an additional 10% similarly in snowboarders. And when we look at the top most common specific diagnoses among skiers and snowboarders, we find what we've known for years. Skiers sprain their knees and snowboarders fracture their wrists. Another common injury among skiers and snowboarders, accounting for close to 10% of injuries, is also head trauma, which is concerning. And then because of the way snowboarders fall, shoulder separations and clavicle injuries are also a great concern in this population. Now, so remember that we don't just want to look at frequency of injury, we want to look at burden and severity of injury too. So now we're going to look at the top 10 most common diagnoses resulting in transfer. So these are people who presented to the clinic and needed a higher level of further care, and that's 10% of skiers and 7% of snowboarders. And what I want to point out in blue here are these are the things that are really concerning: head trauma, blunt chest trauma, blunt abdominal trauma. These are the things that if you don't get treated pretty immediately, like they can kill you. That's not to minimize things like lower leg fractures or tibial plateau fractures, which are associated with a high level of morbidity. But I want to point out that in snowboarders in particular, close to 50% of transferred injuries are head, blunt chest, and blunt abdominal trauma. So these are important ones to target. And when we look at why people are getting transferred, collisions with natural objects are responsible for over 20% of these injuries. And then terrain parks are responsible for over 20% of injuries among snowboarders. So that accomplishes objective one of what I wanted to share to you. What do injuries look like and who's getting injured at Winter Park? And Now I want to take you to one slide that demonstrates the relationship or the effect of the environment on injury rates. So now we've shifted from describing who's being injured to looking at injury rates on some days compared to others. And so I'll walk you through this graph. On the left-hand side, you have injury rate ratios and their 95% confidence intervals. And the red line that spans across the 1 means that anything below that line can be considered a protective factor or decreases risk of injury. Any bar that goes over that line can be said to increase injury risk or injury rates. And so if we look at the first 3 that are below that line, we find that on days with poor visibility versus good visibility, injury rates are surprisingly lower. That was an unexpected finding, but we think people might be skiing more conservatively, or maybe the snow is better. When we looked at crowdedness, that was something that Winter Park wanted us to look at. Do more injuries or occur on crowded days, or does it influence injury rates? And we did not find that injury rates were significantly associated with level of crowdedness. And you can see that as the 95% confidence interval crosses 1, so we concluded that that was not significant. What we did find was that for every increase in inch of base depth snow that you have, we found a decrease of an 8% decrease in injury rates. And if we look at snow, this matters in particular. On days with less than 1 inch of snowfall, we found a 22% increase in injury rates compared to days with at least 1 inch of snowfall. And when we look at sort of subjective snow conditions, like packed powder compared to powder, or hard pack compared to powder, so those really nasty days where you don't want to fall because it hurts, that was associated with a 71% increase in injury rates. And if we look at, if we zoom in on collisions in terms of injury rates, we see an even larger effect of snowfall, in that days with less than 1 inch of snow results in a nearly 50% increase of injury rates. But we did not find that crowdedness or the number of people per acre of land that was open, we did not find that that was associated with collision rates, and we're still discussing why we think that is. So the takeaways from today, the results are generally consistent with previous studies, and that's a takeaway because we've been doing research for a while on this, but we haven't really moved the needle. And so something else needs to be done. Do we target beginners? Is it more education? Do we need binding checks? Should we mandate wrist guards when snowboarders are in lessons? I think a great way to get at injury burden is to look at collisions, because then you get at injury severity and frequency. I also found that the environment is important. Less snowfall increases risk. Snow matters. And I think this is poignant on years with low snowfall, and the fact that we now have the ability to make our own snow. And who knows what's going to happen in the next few years in terms of snowfall. And then maybe most obviously, but I think most importantly, we've identified pretty obvious areas for targeted efforts based on information that's readily available at resorts. And that demonstrates just real world practicality of collecting this type of data and its potential to influence decision making. And like any study, this one and our data collection suffers from limitations, particularly since this was an injury-only database. I can't actually tell you if snowboarders are at more of an increased risk compared to skiers because I don't have any information on the non-injured snowboarders. So that'll be an extremely important future direction for future research. But our database is large, it spans 5 seasons, it consists of definitive diagnoses, and we actually have 4 peer-reviewed publications that have come out in the past couple of years using this data, and we plan to do more studies. And it's, this is particularly meaningful in Colorado. But when I think about future directions and implementing injury prevention programs or trying to get people on board, I think about balancing real world constraints with what these researchers really want to do, which is like well-controlled randomized clinical trials and prospective longitudinal cohorts and things like that. And I think that those are very important, but there are real-world constraints that resorts have to work within. And so we want to ask the question, how can resorts and stakeholders develop and evaluate injury prevention efforts? Now, the icon that I brought up demonstrates, it shows some of the injury prevention efforts that already exist, but to my knowledge have not been empirically evaluated. And my final point is that I think, I'm going to make a plug for injury surveillance as a logical next step to really help get at the injury prevention heart of the issue here. This 4-step sequence of injury prevention just says that you need to collect information on the extent of the problem, figure out why injuries are happening, introduce a preventative measure, and then assess that measure by repeating step A. And so if you have a system in place to do that, we will be able to accomplish better injury prevention. Right now, we're kind of stuck at A and B. So future directions should include C and D as well, and injury surveillance where you collect large amounts of information across multiple resorts could help accomplish this. And research and studies are not done in isolation. I have a lot of people to thank, including my committee and people who helped me extract this data. And a big, big, big thank you to the Winter Park team, Winter Park Ski Patrol, and Winter Park Management. Without their participation, this would not happen. So I thank you very much for your attention, and I am excited to see what Scott and Amber have to tell us next.
Thank you, Lauren, and please take it away, Amber and Scott.
Okay, let me work on sharing. Here we go. Okay. Can you all see my screen okay? Great. Okay, well, as mentioned, I'm Amber Viitanen, so I work at CDPHE. And Scott and myself both work in the EMTS branch, so that's Emergency Medical and Trauma Services. And we kind of head up the data section. So we fulfill lots of data requests, do analysis, work on improving our data collection platforms, a lot of linking between our systems. And we spend most of our time looking at both EMS, the data from the ambulances, and data from the trauma registry. So I'm going to start out today by telling you a little bit about the EMS data, and then Scott's going to kick it off, or I should say finish it up with the trauma data. So our EMS data repository is a collection of electronic patient care reports, what we refer to as EPCRs. Each EPCR has 269 required data elements. We have information on patient demographics, medical history, injury or illness information. One of the key differentiating factors is we also have really good information about where the injury or accident or illness occurred. So incident location information, as well as times, along with whatever sort of procedures or medications were performed by the EMS provider. Also, what's really nice is that we follow a standardized data standard from NEMSIS, which is the National EMS Information System. So every state across the nation follows this national standard. So if you want to compare EMS information in Colorado to Arizona or Wyoming, we all collect the same data elements the same way. Additionally, NEMSIS puts this all together in a non-identifiable format so that you can have publicly available the research data set. And so from last year, there were over 43 million records alone. So there's lots and lots of data about what's going on in ambulances and the patients that are being treated. These data are being used more and more to inform clinicians, policymakers. We had a couple bills this year come up related to EMS data. They help us optimize care in the state and nationwide. They're always enhancing new protocols and standards. We use it to surveil different topics such as COVID, or influenza or opioids. We also use it to evaluate our EMS system. And then most importantly, we do a lot of reporting out of the system. So there are over 900 scholarly reports or peer-reviewed journals and other publications that have used NEMSIS data, and those are all available online. So this is definitely an up-and-coming data source. In Colorado specifically, these EPCRs, patient care reports, are required to be submitted to us by all licensed ambulance agencies anytime patient contact occurred. Now, it's always important to identify limitations of your data, so I want to be very transparent about what we do and what we don't have in our system. So when we say licensed ambulance agencies, that means that the entity has to A, have an ambulance, and B, be licensed. And licensing occurs at the county level in Colorado. We are one of 2 states in the nation that do not license at the state level. So our data only reflects transport agencies. So for example, if there were an incident that occurred within Denver, Denver Fire Department, because they do not have an ambulance and they do not transport patients, they are not required to submit information about the care they provided on scene. Rather, Denver Health, the ambulance agency that does transport patients, they do have to submit their information. The other important factor is because licensing occurs at the county level, we actually don't have a great enforcement mechanism for data submission at the state level. So we have written in rule that they are required to submit their data to us by these standards. However, we cannot take action on their license if, say, they don't actually participate. Now, we do have some mechanisms of communicating with the counties themselves, and they can take action, but it's important to know that sometimes we don't have 100% compliance with all of our agencies, again, because we don't have that enforcement piece. Another important piece to mention is that currently rule states that these EPCRs are required within 60 days of that patient contact. Now that's a really, really long time by data standards, especially if you're trying to do syndromic surveillance or real-time surveillance. We're actually in the process right now of updating those data rules to better align with a lot of the other states where usually that requirement is about 24 to 48 hours. So as I mentioned, we follow the national standard. Our data set includes all the national and state NEMSIS version 3.4.0 elements. You don't need to know what that means, but if you're curious, you can Google it and see every single one of the data elements that we are required to collect. We have over 200 Colorado agencies participating, and we get about 700,000 records every year. And as I mentioned, most importantly, a lot of what we do is fulfill data requests. Last year alone, we fulfilled over 100 different data requests using EMS data. And that's what drives a lot of the research or the deeper dives we do on particular topics. So especially with this particular study, it's important to mention that we're not the researchers here, we're just fulfilling data requests. So sometimes if you have questions about specific methodology, just remember that's usually determined by the requester of the data because they're the ones doing the research rather than by our data team. So talking specifically about this study, we got this data request from a gentleman from Siegel Public Affairs. He had a very emotional investment in this topic. He wanted to know about snow sport injuries across the state. And I think, as Lauren may have alluded to, we don't necessarily have a centralized repository for these types of injuries. Each resort may collect information specifically about what happens at their resort, but there's no state or national database that we can pull from. So this gentleman reached out to us and said, what data do you have to help us answer this question? So we looked at EMS transports. So that's anytime a patient was actually moved from a scene from 3 different seasons. So we transitioned our data standard in 2018, which is why we only have part of the ski season here, because the data we collected in 2017 is very different than the data we collected in 2018. So we looked at January through April 2018. Then we had a full what we called ski season, which was defined as November 14th through April 15th. And then the third ski season we looked at happened to be cut a little bit short because guess what? A pandemic hit and most of the ski resorts closed. So we only have data through March of that particular year. Our inclusion criteria was similar to what Lauren had mentioned. We looked at only patients that had specific ICD-10 codes that referenced snow sport injuries. And I'll dive into what codes we use specifically later on, but it had to be listed as the cause of injury. And then finally, we looked at all of these snow sport injuries that occurred in a zip code where there's known to be a ski resort. Now, this is another limitation of the data. Our requester identified these zip codes, so they may or may not encompass all of the Colorado ski resorts. Additionally, it's possible that you could get a ski or snow sport injury, not necessarily at a ski resort, but maybe within one of these zip codes, so it's important to note. But after all of our inclusion criteria, we came up with just over 4,000 records from these three kind of 2.5-ish seasons. This was a really interesting study because after we presented the data, it actually got picked up by the Colorado Ski Country USA, by Colorado Sun, by Westward, and actually a legislative bill was pushed and proposed to require some sort of Colorado specific data reporting. That ultimately didn't get passed, but this is definitely becoming a more and more popular issue. So looking at EPCRs by month, obviously we don't have the same type of information that Lauren has, but we have some similar pieces we can look at. So there's definitely different trends year over year. And remember that January and February are the only two complete months that we captured in all three of the ski seasons. And there's, again, some variability, could be related to better snow seasons. We're not quite sure there, but we do see that there are different trends, upward, downward, interesting pieces to look at. So I mentioned ICD-10 codes, and Scott will dive into this a little bit more when he specifically talks about the trauma registry. But in the EMS repository that we look at, these were the ICD-10 codes that we identified. So we do have some suggestions for what cause of injury codes we want folks to use, but they do have an opportunity to input any of the, I think, 10,000 different ICD-10 codes. So of the ones that we looked at, the most common was the generic one, which is no surprise for EMS providers because they don't have time to sift through thousands of ICD-10 codes. So they usually just pick some top codes that they use over and over again. So that's why we have that generic code. And then we do have some folks using some more specific ones like the snowboard accident versus the ski accident. And sometimes they do dive in a little bit deeper to identify some of the other pieces that Lauren alluded to, the colliding with an object or another person. Also interesting, but probably not surprising to most folks who do participate in snow sports, we found significantly more injuries in the afternoon. Most injuries occur in the PM rather than the AM, which, you know, you get tired legs. Also, there might be some sluggish behavior after food or alcoholic beverages, up to you all to decide. And again, aligning with what Lauren had mentioned, our most common age group that we saw was 20-something-year-old males. Those are most frequently the injured patients that we saw in our registry. And I'm really happy we looked at things in a similar way, not knowing what Lauren's study had all reflected, but we did look at the same kind of question, where are folks getting injured? And we saw mostly it was the lower extremity. Again, she alluded to the knee injuries. We saw a lot of head injuries as well as that upper, you know, those would be your wrist, shoulder. that type of thing. So some alignment there between our data sets, definitely. And then we also looked at GCS, which is the Glasgow Coma Scale. This is an indication of your mental state or alertness, how responsive you are to different types of stimuli. The higher the score, the more alert. This is particularly important for head injuries and can kind of be an indication of severity of those types of injuries. But we do see a bulk of our incidents, our records here reflected that higher, more responsive state. And then another way that we tried to capture severity is to look at the mode of transport. Did they go by a ground ambulance, or was it a dire emergency and they had to go by air ambulance? So fixed wing would be those like actual airplanes that go from an airport to another airport. And then a rotorcraft is those helicopter transports, which oftentimes become pretty difficult on those really snowy days. So before I hand it off to Scott, I just want to mention that kind of all three of the studies that you're seeing here, we are all getting at different pieces of this picture. While we don't have one clear repository that has all the injury information about all ski injuries, Lauren could dive down deeper into that more specific single ski area. This is a statewide view, but again, it only looks at the information from patients who are transported via ambulance. And then the other piece that Scott's going to talk about is the trauma registry. And those are folks who had significant enough injuries that they made it into this trauma registry. And he'll dive into some inclusion criteria there. So we're all sort of triangulating into, I think what the overarching question is, who's getting injured? How are these injuries occurring? So with that, Scott, take it away.
Thanks so much, Amber. And great report, both you and Lauren. That was really great. EMS just has such a large role as it plays out here in Colorado. If it's not medical, it's behavioral. If it's not behavioral, it's trauma. And the portion we're going to focus on today is the Colorado Trauma Registry, and it's a computerized database, and it's really housed within each of the primary hospitals within the state. And they rely heavily on EMS to collect a lot of the information. The registry collects information from the scene of the incident to the patient outcome once they leave the hospital. So we work with the hospital systems and their software vendors to collect the information from multiple sources. We write all the code out to define what needs to be collected, and then share that with their software vendors. The hospitals can then submit all that information, the demographics of who got injured, the information pertaining to the injury, and again, anything related all the way from the scene to the patient outcome. So the information is really used broadly. As Amber mentioned, the national effort in the EMS, there's similar initiatives at the national level for the Colorado Trauma Registry. All the information is transported up to the National Trauma Data Bank. And it's also used, with our state councils and regional coordinators to make decisions. The systems run smoothly when working together. So we have a lot of coordination with EMS and trauma. And we use the data to help define our guidelines, transfer protocols, and set benchmarks. As Amber mentioned, there's always a lot going on in terms of bills and rules pertaining to data. So it's an evolving system, but we've really come a long way. We commonly add on new hospitals every year. Every year, hospital systems are looking to improve their designation level in the state. We currently have 6 level 1 trauma centers, similar to level 2s. They're both really high levels of care. They can pretty much cover any incident, any trauma that comes in, they're ready for it. What Lauren pointed out is that a lot of the level 4s and 5s, and even these non-designated freestanding emergency departments do not have the capability to take care of a severely injured patient, yet they're most commonly found in those rural areas. And it's a very long commute to get to a level 1 or 2 when you're injured at a ski resort. So we commonly see a lot of transport information in the trauma registry. where a level 1, 2, or 3 might document that the patient actually did come in from EMS through a level 4 or 5 trauma center. So we get about 30,000 records a year, and that can easily go to 40,000 depending on how you slice and dice your data report. But yeah, we have everything from the first incident to the transport and even the readmissions as necessary. Next. So to become a trauma patient, it's more than just having a traumatic injury. You know, a minor boo-boo scratch is not going to meet it. You need to have a primary diagnosis that is trauma. So that could be the fracture, that could be the burn, you know, blunt injury, penetrating, gunshot wound, motor vehicle. It has to be some sort of fracture to the bone or contusion or hemorrhage, something pretty serious. And then once within the hospital system, you have to meet additional criteria. So either dead on arrival or in the emergency department, or death as an inpatient, and you're automatically in the system. As well as if you have a long admission stay, if you go for observation and have a injury severity score of greater than 9, or really any admission as an inpatient to the floor, to the intensive care unit, telemetry, any general admission, operating room, or even a direct admit where you bypass the emergency department and get immediately admitted. So that's kind of the criteria. Usually that most patients meet trauma criteria, but this next one here, patients transferred from any trauma center to another trauma center is automatic inclusion. So what we're saying there is a lot of those level 4s and 5 records that get transferred out end up showing up at a level 1 through 3 for more definitive care. And then the last inclusion too is if you need to come back for any work that was done at the hospital that wasn't completely cared for, then that would be considered a readmission, and that patient also makes inclusion into the trauma patient. So, so again, it's going to be more of your serious injuries that show up in the traumatic, in the Colorado Trauma Registry. So I just wanted to mention a little bit about ICD-10, which is the International Classification of Diseases. We basically have 2 versions. The 9th version, which started really in the 70s and got adapted a little bit more into the 80s and 90s. And that was the primary coding convention used to document all kinds of things in the hospital, the diagnoses, the procedures, the location, the cause, all these nuances about what happened. We switched to the 10th version of this injury classification system. And what that did is it really expanded your specificity, how you can kind of describe the injury events. So I'm going to kind of go into it a little bit on the next slide, but I think as Amber showed, we're going to more specific codes. So let's go ahead and look at the next slide, where in ICD-9, we use what were called E-codes to define the causes. And there was some information like fall from skis, but it didn't have the specificity that we see in this new data collection classification that started in 2017. And this was adopted in both EMS, but can't be quite applied as well as it is in trauma, because in EMS, it's harder to have the definitive care to get these specific codes. But that's why in trauma, we were able to find these no problem. So yeah, as Amber mentioned, there's so many hundreds of thousands of these different types of codes, depending on if you're talking about injuries or diagnoses or causes. And but when we specifically look at the cause codes, we can see in ICD-10, we were able to get that greater specificity to separate out falls from collisions from ski lift injuries, and then another larger group for any other snow ski incidents. So I just kind of want to introduce then that ICD-10 concept, because it really is some of the backbone of how coding gets kind of converted into the actual categories that make more sense broadly. So, all right, having described all that, then let's kind of get into a little bit of this small cohort we're going to look at today, and that's the snow sport injuries. For our report, we looked at a 1-year time frame. At the time when this request came in, the trauma centers were still reporting on their data for the following year. So this ended up just being a one-year report. We kind of looked at what was approximately a ski season, November 14th, April 15th. But one of the limitations is that for this particular time frame, the injury dates were not always coded very well. So we actually went with the hospital discharge date. Just a little nuance, it would be a difference of a couple hundred records though. So just kind of want to illustrate that this number of incidents is definitely just ballpark, and it can vary quite a bit just depending on how you set up the report. But as I mentioned, we excluded out the readmissions and the transfers out. So the final inclusion criteria, now that you've been considered a trauma patient, is to say, okay, we want to look for trauma patients that sustained a snow sport injury and were injured in one of these 25 injury zip codes. So these are the, on the left, where they kind of classified 7 cause codes that we used to determine our cohort. And then we looked at the 25 zip codes where the ski resorts were located. Okay, so from that point, then kind of one of the questions we can ask, I think, we had quite a few tables that didn't make it into the particular report, but one thing we wanted to highlight was the mode of transport. How does the patient arrive at the hospital? And about 7 out of 10 times, you're going to see that EMS was involved. We still have a relatively high percentage, 7%, coming in by personal vehicle. Unfortunately, we have some unknowns just to some lack of data quality or issues with mapping that can happen. But I think we can assume, again, at least 7 out of 10 of these incidents are coming in through EMS. And this next one looks at the injury severity score. So when a patient comes in, their anatomical injuries are fully assessed. And if there are multiple injuries, that information will collectively be considered, and injury severity score will be derived. And what we see here is that over 90% of the injuries for this snow sport sample were considered minor or moderate injuries. So on this scale, it appears that they're relatively minor or moderate. However, that does not indicate that a lot of care was not done in the hospital. It's just that the severe and critical scales are truly almost life-threatening. So when you're up in the 25 plus range, there's a good chance you won't even make it, or you're going to be in hospital care for a long time. So I just wanted to highlight that although over 90% are considered minor and moderate, when we look at this next slide in terms of ED, and we can go ahead and look at that, we're going to see that there was still a lot of care going on in terms of how was the patient, what happened to the patient when they arrived at the emergency department. And we can see that the first, the one that's most prevalent is that the patient was taken to the operation room. So although the majority are considered minor and moderate injuries, it's still a lot of care in the hospital. So about 35% go into the operation room. And then the other admissions, direct admit means that the severity was usually great enough that they even bypassed the emergency department and went right into an inpatient care. We have intensive care rep for over 119 patients. And then again, and some were discharged home, about 18.5% ended up being discharged home. So somewhat of a gamut. And then I think that the last slide after this kind of shows, again, kind of what Amber and Lauren both highlighted on was what kind of injuries did these people sustain? So we derived this information from the ICD-10 codes. So the hospitals submit thousands of diagnoses codes for all the anatomical injuries. And what they do is assign a primary diagnosis, which is really the nature of the reason for their being there, the most severe injury, why they're there. And we convert that code to a classification. And in this case, we're highlighting the nature of injury. And again, we're seeing a whole lot of fractures and internal organ injuries as our main highlights of the reasons why they were admitted for trauma care. So that summarizes my report. I'm gonna hand it back over. Thank you very much.
Thank you very much, Scott and Amber. And we have just a couple minutes left. I'm going to try to squeeze in 2 questions if I can. And if you have a question, please feel free to type it in the Q&A. My first question is for anyone, but maybe particularly Lauren, is, do you have any thoughts, or have you thought at all about how global warming may potentially impact ski injuries going forward? I know you mentioned that, they could be lower. We shouldn't think that we should strive for more. And it seems like snowfall is related to injury. So just if you've thought about that at all.
Yeah, have I thought about that, in a personal, selfish way also too? Like, we all want really long, powdery ski seasons, but yeah, if I had to throw my unverified, unsupported opinion out there because there's no data on it, I would gander that as less snow would equal more injuries. What's very interesting, what I didn't parse out in my data, is that I did have a section on man-made snow. But I had to exclude most of that because it was, maybe on 2% of the days that we were able to look at injuries that occurred on man-made snow. But I think as we should be concerned about the effects of global warming, not only on our recreation, but our injuries as well. And then water resources too, because snowmaking doesn't just happen. It requires a lot of energy and it requires a lot of water.
Yeah. Great. And my next question for all of you, using different surveillance systems, different data sources have highlighted the strengths and weaknesses or limitations of these data. If you had a magic wand, are there data elements that, if only we had, or data that we could harmonize if only we could? Dreams are fine, but even things that we could do practically that would make these questions easier to answer. I'd be interested to hear that from any of you.
Well, if I had a magic wand, I would love to be able to look at the spectrum of care. And so what that means, what were they doing at the time they got injured? You can follow them to ski patrol, and then you can follow them, what was their ultimate outcome? I do think that is important because ultimately we don't have any studies on how people do apart from elite athletes. And then the second one is, honestly, if I had a magic wand, I would I would give every ski resort electronic resources to be able to record and share their information in a cloud-based effort.
Yeah, I second what Lauren had mentioned with the whole continuum of care. I think that's something we've been striving for a long time at CDPHE, but from the time of the injury all the way through not only EMS and trauma facility, but when we talk about rehabilitation centers and long-term effects and those types of indicators, I think that's been a long time dream. And I know that, as I mentioned, there was a bill that was proposed to have a sort of repository for these data in Colorado. And I think one of the biggest setbacks there would be if Colorado was the only state reporting these data. It would look like, oh my gosh, everybody's getting so injured in Colorado. So I think there's definitely a need at the national level to have more of these conversations so that we can compare apples to apples, across different ski resorts in different states.
I would love that. I would, place that little argument in people's minds that we could be the first and the leaders in it, and not be so we can measure our injury prevention efforts by having that available.
Well, thank you all for joining us today and for the Q&A discussion that happened as well. And just a reminder again, as we close, that our next webinar is Tuesday, August 10th at 12 p.m. Mountain Time, and looking at child maltreatment prevention and fostering healthy futures. Thank you. And with that, we'll end the webinar.
Thank you.